get this in front of me. So I'm going to first introduce the closest to me, Donnalee Lozeau. Donnalee currently serves as Chief Executive Officer of Southern New Hampshire Services. Donnalee is pleased to have returned to the nonprofit agency where she worked as the Director of Program and Community Development for 15 years, while serving as a volunteer legislator and before being elected mayor of her town. She's been at Southern New Hampshire Services for 21 years and has multiple honorary doctorates in humane letters, public service, and another humane letters. She's like done it twice. That's good. And attended Revere College. So welcome, Donnalee. And our next panelist is, our next panelist, we have like the Donna theme going on today. Donna Harbison. Donna Harbison currently serves as the Director of Care Coordination for the New Hampshire Harm Reduction Coalition. As part of her role, she is facilitator for the 3 community care teams in Stratford and Eastern Rockingham counties. She was an integral member of Region 6 IDN's Community-Based Care Coordination Team and advocated for the CCT to continue upon the sunset of the IDN project. She has led compassionate implementation of harm reduction strategies for the NHHRC in their care coordination programming in Stratford County, Concord, and Manchester, whereas the team provides direct service connection to resources, overdose prevention, and syringe servicing programs. So thank you both for joining us. So I would love, and whoever wants to go first, you can duke it out. We'd love if you could take about 5 minutes to describe each of your models, whether they're in practice today or being worked toward. And so we'll take turns and then we'll flip to the questions after. Go ahead, Tom. And then microphone in front of you too. Sorry, guys.
Good morning. So I want to begin by just mentioning that Southern New Hampshire Services is a community action program. We have 5 of them in the state of New Hampshire. Ours works in both Hillsborough and Rockingham counties. I look at my work as continuing public service without the campaign, which is really a big win. Just saying. So I live in Nashua, but I work out of our Manchester administrative offices. We have 10 resource centers throughout the 2 counties. We service a lot of elderly housing. We have almost 1,000 units statewide. Earlier when somebody was talking about, helping the elderly get into, more livable, accommodating space that isn't necessarily a nursing home, really does free up other apartments and homes in our communities. And so finding a way to do that, I think, is important. So I think some of you may have heard of the NERAP program. Just checking the room. Yeah, okay. So $230 million invested in our people since March of 2021. Things changed a little bit this past weekend. And the first thing I like to tell people is don't panic and take a breath, right? Because we have to figure it out. And I don't want the people we serve to be panicked. So we didn't have any money taken away from us. People so they revoked the money from ERA2, which is the second tranche of money. And the answer is no, we still have that money. When we received that money, we knew that it was going to end December 29th all along. But we did ask for additional funds, which we were not selected. And the jury's still out on how that's going to play out, and that's not what I have to do. But prior to that, and because we knew that this program was going to end in December, we tried to do a lot of legwork around, so how do we help people, right? So I would say there's a fair amount of people that responded well to our workforce information that we sent out. So about 6 months into the program, we mailed out flyers to everybody that was participating to say this could be a great time to look at getting trained, getting certified, getting a job you'd rather be in. We can help because this is a good time because there are other things that are taking care of some of the demands that you carry around on your back. Then there's a group of people that we're here talking about today, which are the people that are homeless. And whether you define it as couch surfing or living in a tent, there's different stages of homelessness, and there's also different stages of readiness for help. Everybody in this room knows that. You don't need me to explain it, right? I spend time talking to elected officials and policymakers about the dangers of treating homelessness the same for everybody. Having served as the mayor of Nashua for 8 years and driving Bob Mack pretty much right out of his mind, I can tell you that everybody's an individual, just like everybody in this room. We couldn't solve all of your problems with one fell swoop. We have to treat you as individuals. We have to understand where you are, why you're there, and what it is you would like us to do to help you, and whether you're ready or not ready. And so that is beyond the scope of what my agency can do. So Head Start, fuel assistance, workforce, those are all things that we can do. Mental health, substance abuse or misuse, homelessness, that's not what we have the skill set to do. So I'm a roundtable person, and I think that if you bring the right people to the table, just like you saw the mayors today, really wonderful things can happen. And so I made a proposal to Gopher, I don't know where that came from, and to New Hampshire Housing Finance Authority about trying to take kind of a different approach to now what are we going to do that we're running out of road, and can we do it a little differently? And the proposal is to look at doing wraparound teams. I proposed 2 of them. One for, I call it the very intensive team that would work with the folks that we have put in hotels and that are on the waiting list for hotels. And the other one working with people that I call precariously housed because they've had trouble paying the landlord. Sometimes they're not the best tenants, that sort of thing. And so it's recently been approved that we can do something like that. But now that the additional money isn't coming, it's hard to pivot to run that and at the same time try to make sure we take care of all the applications in the queue. We anticipate we can pay all the applications that are in the queue, but I don't really know for certain until we can touch every application. Because your application might be $2,000 and yours might be $5,000, and if we would have thought they were both 2, we're in trouble. So I'm going to focus our efforts on the intensive team, and we're going to look at the dollars that it would take to do that. Now, when you say wraparound team, all of you come to the table and work together all the time in your communities. What I proposed is that the one thing that we can bring to the table for as long as it lasts are the dollars and the resources to do this work. So I've reached out to agencies that we typically work with to ask them if we could cover the cost of a staff member to participate in this table. So that it gives them the opportunity to kind of replace that divot for a little while or whatever the case may be and let us start doing this work. I've had great feedback. I'm hopeful that, sometime before the end of the second week in November, we can have some concrete plans about how we're going to do that and how we're going to start. And I think it's important that we focus a fair amount of dollars, or we provide the data to the governor's office around what would it take to keep people housed through the winter. And when I say that, I'm talking about the people that don't have housing, that are in the hotels, because we can't focus on everybody that I've just identified. So I don't know if that was a 5-minute nutshell or not, but
I thought it was great. I learned a lot. Thank you. Okay, I'm going to be honest. This is the first time with a microphone. I'm pretty loud, so usually I can project my voice just fine. If anything weird goes on, please somebody wave to me and let me know. Again, thanks for introducing and having me here today, Stephanie. I joined on to the IDN Region 6 in 2018. So I'm fairly new on the scene of New Hampshire and its housing issues and complexities.
Bring out your American Idol. You can do
all
it.
right, we can do it. All right. So I came on in 2018 with the IDN, who had already an established community care team. So I did a little history searching this week to see where the CCT kind of began and how it started. And it's interesting that it sprang from the Greater Seacoast United Way, their Home for All program, and they had Maria Solari as the facilitator, and it started as a group of housing supports and advocates. So it's pretty fitting that we're here today in this capacity. As the IDN project went on, it became more clinical and social mixed together. So then Tori Jennison was brought on and Sandy Denoncourt. At that time, I worked with the community care team, which was out in the community doing the community-based CTI model of transitions. We were working with people that were getting ready to transition into homelessness, into housing, which is the opposite of what we're talking about today. But so it had already had this robust start. There are over 63 organizations that participate in the release of information and have signed on in a confidentiality agreement. So I haven't been able to look at the new numbers lately because we're moving everything into a different secure storage. Last I checked, there was at least 125 active members of the community care team. So these teams happen. There's one in Exeter, there's two in Stratford, and there's one in Portsmouth. We connect on a monthly basis based around a shared release of information for individuals that we all tend to work with. We have a lot of duplicative like contact points with individuals. And these are the most vulnerable, the most complex. The majority of folks have Medicaid from the state Medicaid's program or Medicare. High utilizers, if we want to use that term, which I don't like, but they frequently utilize services. They may be in and out of the emergency room. They may be unstable in their housing. They may have a hard time staying connected to their primary care, kind of fall in and out of the view of their MCO, their managed care organization for the state Medicaid. So what this community care team strives to do is we strive to come together based on a strengths-based approach to identifying the client's needs and how we can all support that individual in that process. We have the folks from the city welfare office, from the local shelters, housing authorities. We have the MCOs on board, the community mental health centers. And so when we do meet, it's just for an hour. We do have that signed release of information, and we are able to identify the critical need. It's an opportunity for us to say this individual has been missing their dialysis 3 out of 5 days for the past 2 weeks. What is the barrier? Well, the MCO, the primary care, we can determine, maybe it was a transportation confusion. Maybe the individual forgot what time their chair appointment was for. These kind of critical need for the most vulnerable. This is something that we can all come together to do. So this platform, in addition to working to support these very vulnerable community members, also provides a platform for organizations and providers to come together and build relationships with each other. So that is one of the key pieces of this group, is being able to know what, Dave, I'm going to use you from City Welfare as an example. So now we can know, what is it that Dave is doing? Why did he make that decision in the hows and the whys and the whats of what everybody does? It reduces confusion. It speeds up productivity in terms of getting folks connected quickly. And as we all know, uncoordinated care is more expensive. It increases risk to individuals of losing touch with services. It's confusing for patients. It's confusing for providers, why are they not showing up? It also aggravates clients, and then you have clients coming in feeling as though you're not able to do your job and your end of the bargain, and that in turn leads to staff, burnout and losing folks in the workforce. So the idea of the community care team, as much as it is about supporting an individual with complex needs, it's also about supporting us as workforce and how do we all work together and stay connected.
All right, thank you. So now we'll do some questions. I'll go back and forth, okay? So Donnalee, what has been the experience in engaging providers, and what types of providers? I don't know if you mentioned that in the opening. What types of providers are you talking to consider joining this wraparound model?
So you start with the first one, right? And so if you're in Manchester and you want to get the right people to the table for a project like this, you call Anna Thomas, right? I mean, Anna has huge ideas about, what's going on and what role public health is playing in all of this. I spoke with the welfare director. I spoke with Chris McCracken. I spoke with Waypoint. I spoke with, I haven't spoke yet with the home health care for the homeless, Rosanna, I think. Yeah. But so groups like that to say, if you could, and if you could you do this, and what would it take? Give me a budget, and let's see what we can do. And so far, everyone that we've talked to is willing to commit to the effort. And I think really it kind of just starts to get people excited. And I always ask the question, so who's not at the table, right? I mean, the group can't be 40 people, but it can be key people that also connect to others in the community. I mean, when I was sitting here this morning listening to Keith and the folks from 1269, I'm thinking, yeah, purpose is so important. So is there something that we can do together with our workforce programs that could potentially connect some of their clients to what else do they want to do? And maybe, in the evening they can do the 1269 work, and during the day maybe they have a different job, part-time, full-time. What is it that they need? How can we help them? Are they interested? And those are, I think, the things that we need to do, is make the right connections instead of duplicating each other's efforts. If we could build on each other's strengths. And there are a fair amount of projects in my lifetime, both through Southern and through the work I did as an elected official, where time and time again that model is the one that breeds success, whether it's a complicated road project or a water project, or one of my first projects at Southern was when I worked there, in the 90s, was a project called Mary's House, which is for homeless women in Nashua. Everything at that time had housing and help for women that had children, but they didn't really have anything for just women. And I mean, I remember meeting Dolly Bellavance in the parking lot of Macy's to give her the grant that had to be at DC. She had to sign off on it. We had to get it to the airport, because we just barely made it for the SRO funding for Mary's House. And Mary's House was a partnership between a business who wanted the first floor of the building that we wanted to buy in the basement because they're a wallpaper and paint store. They didn't need the top three. We didn't need the bottom two. And we just all kind of just came together. And it's worked for over 25 years now. So, I mean, those are the things that if we just think together and we capitalize on each other's resources, we can really move the ball.
Thank you. So Donna, similar question. Has there been any challenges to engaging providers around the table for the CCT?
I think in terms of challenges around connecting individuals, a couple of unique things happened. These meetings used to be in person. They were held at, within the various hospitals in Portsmouth, Exeter, and Frisbee. And, once COVID happened, that stopped. And we started doing like daily touch points. We did weekly meetings around the providers and kind of continued to support that and stay up to date on the last minute information. I feel like now it would probably never go back to in person because it's so effective as a virtual model. I think We generally have probably around 20 people in attendance at each one. I know I said there's over 125 members, but clearly they're not all attending each one. So we have about 25 members that do attend on the regular basis. I think the only challenges that pop up was during the transition when the IDN was sunsetting and we were taking on at NHHRC the CCT model of there's always some you lose some in transition, right? Because all of a sudden people saying, oh, it's not happening anymore, but it is happening. So I think now it's been, a year and a half, we're kind of settled in. The piece that I find a challenge is staff turnover in organizations, especially big hospitals. Especially there, that is where, if the one person who was attending CCT moves and shifts to a new role or to a new job, we kind of lose that contact. And that's the scramble. And that's something we look at on a regular basis. Right now, I'm reaching back out to all the hospital contacts. Do you still work there? Who is there? How can we get you all connected? Because our support that we can offer for individuals that are either inpatient for long hospital stays, that care coordination on the transition out, or those that are back and forth into the emergency room and unable to connect with their providers outside, we need the hospital at the table to be able to support them in that. Other than that, the only thing I think is I would love to move towards having more CCT members just reach out ahead of time with identifying the individual that they want to present or that they want to touch base on, just so that we can streamline the meeting. As a facilitator, sometimes they may only have a couple of folks on the board to talk about, and then there's other times where there's 9, and you're like, okay, I got to be able to pace this along so we can get to everyone. Those are really the only challenges I see. I see nothing but benefit of a community care team. For me, this is the ultimate harm reduction, and that's why I was really adamant, and I'm so grateful that Lauren McGinley, our ED, was on board with me, just being able to take this on. I just couldn't just let it wither. It's much too important. So.
Thank you, Donna. Donnalee, this is our favorite question, or least favorite question.
Ready?
What do you envision around the possibilities of sustainability for this model?
So obviously the funding ends. I think we've already heard that, right? It's my hope that some of the resources that remain, for some of our housing funds, a lot of you know about rapid rehousing money, ESG money, state money that, Melissa could probably give you chapter and verse of. What my hope is that the team will find the success from this model and will just make it part of their regular routine. So right now, all of us don't have enough staff. And of course, the staff that I have working the NERAP program, there's a fair amount of them that are from temp agencies, and there's a fair amount that we've made permanent employees. But, I've lost over 20 employees just in the last 10, 15 days. And so that's not helpful. But all of us have that problem, right? I sit on a hospital board, as Kathy knows. I, sit on the Plus Company board. All these places, wherever in particular there is this face-to-face, kind of work that we do, they struggle more than the businesses that we're hearing are struggling. And when you're competing with Dunkin' Donuts paying $18 an hour, and Amazon and some of those, it really makes it hard to get people to not only to work, but to come together. But what I'm hopeful of, Stephanie, is that if we can run this model, let's just say for, the next 3 months or whatever, and people see the benefit of bringing our efforts together, they'll see the benefit that they'll keep their staff person there, because maybe together we can do more work than we could do individually.
Thank you. Donna, what experiences have you had related to authorization of care? It's a fun topic.
It's over my head. Can you elaborate as to what you mean
So
by
I think,
authorization of
yeah,
care?
you know, I think a lot of people, when we hear about CCT and then we hear release of information, people get nervous, right? There's this nervousness of who's signing what, who are we releasing it to, and you described a lot of members on that list that somebody might be signing a release to. Can you just talk a little bit about that?
Yeah, the release of information is set up as such that it authorizes the release of information to be shared, especially within the community care team verbally. It's not necessarily something that folks would use in between with, how do I want to say that? People do get super nervous around a release of information. The goal is the agency that is collecting the release from the individual is very clear and goes over that release, what it entails. I think all of us have the understanding when I'm out in the community, when I'm out doing outreach and I'm working with an individual that I think could benefit and I show them this release, I take the time to go over that and to say, I'm not going to talk about anything other than this immediate issue. We're going to talk about your transportation needs, that you have, New Hampshire Healthy Families for insurance, and that the Greater Seacoast Family First is your PCP. I think that is where we are all very clear with people what we are going to use it for and what we're not going to use it for. People do have the right to revoke that at any time. We do have secure storage for those release of information. Our organization holds all the releases. We ask for everyone to keep their own copy, but we do hold and verify that there is a release. And I think that is the piece that's probably the most important around the release, is just I am very careful to make sure that we only speak about someone that we have a written authorized release.
Okay, thank you for that.
Is that enough, you think?
Yeah, that's good. All right, so we have one question for each of you more before we ask the audience if they have any questions. So Donnalee, what are your expected outcomes and best practices that you believe might be the most successful? Where's your crystal ball?
Well, I'll work with the crystal ball because my magic wand's on the blank. It's my hope that, like, as I've talked to some people about this, they're like, well, you can't possibly really change this, through this model. I mean, there's, 100 people on the waiting list at the hotels. There's 100 people in hotels, whatever the numbers are. It's not going to be enough. And I say, well, it's like the starfish, right? The old beach one. I can't save them all, but I save this one. I save that one, right? I mean, I'm not literally talking saving people, but I think that for every person that we can get on their feet, for every person that the community action mission, which is opportunity means all of us. It's not based on your income. Opportunity means all of us. And so I think we're a couple generations into people not believing that opportunity means them. And so I think if we can just get them to have the faith and the hope that potentially they can make it, I think it'll matter. And I think the people doing the work need to feel some success in the work that they do, so that you're able to still put the gas in your tank to get the work done,
Thank you for that. Okay, Donna, last question for you. Can you share any successful outcomes because of this collaboration model that you've been working with?
I think the outcomes that are the most profound are the ones that we can't identify with numbers. I mean, the outcomes that are most profound are these individuals who enter in to the arms of wraparound services to the community care team, and what that means for their life, their health, their mental health, their substance use, their families, what that looks like for them. That is where the key pieces are. When people understand that they have people that care about them and care about their health and want to support them and identify their goals. I think part of what we do in CCT, which is just as important, is how we speak about people is just as important as connecting them with services. I think having the opportunity in these rooms to be able to talk about people, and they're working so hard just to get through what they need to do each day, to remind folks of that in those rooms and be able to say their goal is to treat this one piece right now, and we can support that. I know that's totally off topic of what you probably asked me, but I have lost it already.
Successful outcomes.
Successful outcomes.
You have a quick story.
Thank you. Yeah, so gosh, there's so many wonderful stories, but I think one that sticks in mind was a woman who was older adult, recognized that, once the isolation of COVID had worn off, there was this understanding that her housing was in jeopardy due to her inability to care for herself. And what we were able to find out during this kind of piecemealing everything together, the reason why she wasn't able to take care of herself was because, one, she didn't have access to the nutrition she needed to manage her diabetes, and also was unaware of foods that could also increase her need around dialysis. Like, she wasn't aware of some of the foods that were contributing even more to her need to have dialysis. We also realized that her transportation had been super confusing. There were days people just didn't show up to get her, and she didn't know what to do, so she didn't say anything until housing came to the door and said, you're at risk of being evicted because you're not able to take care of your basic needs, and it's a health hazard. So at that point, we have public health, as part of this CCT meeting. We have the Housing Authority, the MCO, the PCP, and we were able to wrap around, figure out what was going on in about 20 minutes. 20 minutes, this was solved. Everyone was reconnected. I get goosebumps thinking about it because she was not going to be able to age in place where she wanted to be. We were able to solve this within 20 minutes. Supports came in, and that woman is still successfully housed, and it has been 2.5 years. It's all collaboration.
That's a great example. All right, we have time for maybe 1 or 2 questions. Is there anybody who has a question? I'll put on my Phil Donahue hat this time. Aging myself. Explained it so well. Who's out there? I heard a voice, but I didn't see. Oh, okay. Hold on.
My question is about trauma-informed care with your employees and how you make sure that the people who are working for you are looking through the lens of the experiences that your clients are living instead of their own lived experiences.
I'm guessing that's for both of us? Yeah. Okay. So our staff has a fair amount of training in a lot of our programs for exactly that. For example, Head Start, the staff is all trained in that kind of work, as well as working with the parents. In Head Start, we have a parent policy council, so it's made up of all the parents that have their children in Head Start. It's a very powerful model, because they're participating in determining who their kids' teachers are going to be. They vote on the budget, that sort of thing. One of the challenges that we have at Southern is the silos that federal funds put you in, right? So if I have a staff member who works in the Head Start program, they can't take a WIC application, they can't take a fuel application. So we're sending families to, we have 60 programs. That's a problem. And so we've been trying to figure out a way to appropriately braid funding to be able to do kind of a universal app and have staff that will work with a client directly. So our housing folks are trained the way you've talked about, our Head Start folks are trained that way, our WIC staff is trained that way, but if you're doing an intake for a fuel application, they're not trained that way. But it would behoove all of us to have everybody trained. But our staff is very tuned in to parent voice and individual voice, because that's who we are.
I'm glad you asked that, Andrea. I think it's so important, and coming from the realm of harm reduction, you know, for us, we are a newer staffed organization. We've only been staffed for about 18 months. We have 3 care coordinators that are out in the community doing the direct care in Tri-City area, Concord and Manchester. We are the folks that people are seeing out there. We are seeing them I am with someone on a Friday night at 7:30 at night when everything is closed and they are freezing cold. And what do I have to offer them? You know, if they don't want to go into any shelter that may be available, they may not be allowed into any of the local shelters, or they may not be able to wait to get through the 211 process. They just want to keep walking. You know, our care coordinators and myself, we're the last ones to see them, and what are we saying to them? You know, how can you get through tonight? What do you need to not freeze tonight? And we can connect in the morning. You know, sometimes that's giving them a blanket and encouraging them to hole up under that porch, you know, so they're out of the elements if they're not going to walk into the fire department or the police department. So for that, how do you train staff for that? I mean, we do the absolute best we can. We attend tons of trauma-informed training. We just went to a National Harm Reduction Conference. I think for me, again, it's about the staff's collaboration as a team, the support we offer each other, and the collaboration with their peers in the organization. When I know that my Concord care coordinator has a team of individuals that she works with, that she trusts, that she can call and process those things with, that she can get in touch with anyone on the team at any time of day and process those pieces. I think just knowing that trauma is there, it's in our face. We have all experienced some kind of trauma, and that recognition that we are ourselves going to have reactions to people's stories and what's happening. And I think the key thing is you can't train that away, but you can talk about it, so then people feel safe enough to talk about those things and not just try to plow through it.
Did you want to add something?
I'm just anticipating we're done now, and there's not going to be any more questions. So I wanted to just take a moment for a closing point. We that are running the rent program, as you can appreciate, it's not an easy thing to do. We have thousands of applications. The documentation, I know it's going to be a shock to you, but the folks that we serve don't always have it. But I just want to ask you to please help us in not having people panic if they have their application in. We will get to it. We are backed up. Like I said, I have less staff than I had, you know, halfway through the program. What I don't want is for people to panic. You know, WMUR showed up last week when, you know, the news broke and they wanted to interview me, and they had all, you know, and when they were done interviewing me, there was a woman that came walking out of our offices crying hysterically with a baby wrapped on her, and so the camera person saw her and I didn't see her, and she's like, "What's going on?" And the woman's telling her, and she's like, "Would you be interviewed?" And the woman's like, "Oh, okay." So I said to them, "Can you just give me a minute to talk to her before you interview her? You're welcome to do that, but I'd like to figure this out." So when I went to her, she said, "You know, you're the only agency that helped us. I used to have a home. I used to have a job. I have 3 kids. My little Valentino, who was strapped to her, you know, he was born with an illness. Nobody's been able to figure it out. She had doctor papers in her hand. She's living in a hotel. You guys are the only ones that helped. And now it's over. It's over." I'm like, "No, it's not over." And, you know, there are resources that we have to help people beyond the rent program. And so what I said to her is, "You worry about Valentino and I'll worry about paying your rent. And let's just work from there." But it's important, and it's all of our responsibilities to make sure our clients don't have just that much more stress. And we will all do our best together. So any help you can give us, you know, we put a recording on the phone, because if the staff's answering the phone, they're not processing the applications. So thank you. I'm sorry, I just had to make the pitch.
That's all right. So I want to thank Donnalee and Donna for coming up and talking about the vision around how do we bring providers together to try to move the folks that we work with all mutually in creative ways. One that's already been in place for a while and clearly has been successful, and another just really innovative idea to say, how do we make this happen for a population that we know is stressed, is feeling fear, and how do we do that together? So I really appreciate it. I want to thank you both for this.